Next, we have Dr. Advaith. So he plays football, cricketer, father of a son, born in Hyderabad, but brought up in Chennai, Nama Chennai. He's a cornea, cataract, and refractive surgeon from Hyderabad and the founder of Envision Clinic. So he's going to talk to us about the cataract post-refractive surgery. I think if not this generation, the next generation is definitely going to have a lot of people with post-refractive surgery who's going to come. And we have the expert, Dr. Advaith, to help us to deal with those patients. Go ahead, Advaith.
Thank you, Dr. Nishant, and thank you, AIOS, and we have a wonderful team here today. So the topic I'm going to be talking about is how to achieve emmetropia in cataract patients who undergone refractive surgery. I have no financial interest. Now, refractive surgery, as we all know, that 3 decades ago it used to be radial keratotomy. Now we have the PRK, LASIK, the lenticule procedures like SMILE, SILK, CLEAR, and then we have the phakic IOLs like the implantable Collamer lenses. So why is there so much of confusion, and why is it so difficult to actually operate on such patients? Now, why is there a surgeon dilemma for cataract surgery in post-refractive surgery patients? So the topics I'm going to be covering today is the IOL power accuracy, the selection of the IOL calculation formula, the type of the intraocular lens selection, the precautions that need to be taken during cataract surgery for both the RK surgery and the LASIK surgery, counseling on patients pre-operatively, and counseling on patients on any refractive surprises post-operatively. So the corneal parameters that need to be considered are the Q value, or the asphericity of the cornea, the refractive index of the cornea, the central K, anterior and the posterior corneal curvatures, and the spherical aberrations. So this is what a normal cornea looks like. It is prolate in shape, which is basically steep in the center, and it is flat in the peripheral, and then we have a central hill and the annular C. Now, so the corneal, there are some corneal changes that take place after refractive surgery. Picture A is showing your normal cornea. Picture B, if you can see, after a myopic correction, there's a central flattening that you can see in picture B. And in a hyperopic patient, basically the central steepening and a peripheral flattening. And picture D is basically showing you a patient with post-refractive surgery corneal ectasia, which is having an irregular astigmatism because of that. So this is again a patient with post-RK surgery. As you can see in the picture on the left-hand side, you can see the RK incisions. And topography can show you. Topography can basically show you over here on the corneal thickness. You can see a flat peripheral and flat center, and peripheral you can see the irregular astigmatism. In case of patients undergoing, thank you. So in cases of, it's okay. That's all right. So in cases patients undergoing refractive surgery after a myopic patient, you can see in the picture on the left-hand side, a myopic patient, there is central flattening and peripheral steepening, which is again the opposite in a patient with a hyperopic patient, where there is central steepening and the peripheral flattening. So now, in naive corneas, basically the traditional formulas such as the Holiday 1 and the SRKT do excellent job in predicting the post-surgical emmetropia with refractive errors of within 0.5 diopters of emmetropia. However, in post-refractive eyes, these formulas are known to be inaccurate, as both the measurements of the corneal curvature and the regression formulas have sources which contribute to the error in patients having history of refractive surgery. So we're going to be addressing those errors. One of that is the corneal power. Now, basically, after a myopic correction or a hyperopic correction, basically what is happening is after a myopic correction, the central cornea is becoming flatter. Thank you. And after hyperopic correction, the cornea is becoming steeper in the central. Now, this basically leads to an overestimation of the corneal power, leading to a hyperopic outcome after a myopic ablation and a myopic outcome after a hyperopic ablation. Now, the corneal ablation changes the anterior and the posterior corneal curvature. Thus, the assumption of the refractive index of 1.3375 is no longer accurate. Now, effective lens position estimation error. Most of the theoretically based IOL formulas like the SRKT, the Holiday 1, 2, Hoffer Q, and the Barrett universal formula, these basically use both the measured axial length and the keratometry to estimate the effective lens position. Now, there is an inaccuracy in the keratometry reading. Why is that? Because the manual and the automated keratometry, the reflected Myers, are within 3 mm of the optical zone. Now, the corneal power given is basically derived with the assumptions of the corneal index and the relationship of the anterior and the posterior cornea. To measure the true corneal power, both the anterior and the posterior surface must be considered. So let's look into the IOL formulas that are required for patients with RK. Now, Dr. Nishant was talking about maybe after a few decades, we'll start seeing patients post-refractive surgery. So we are seeing a lot of patients who undergone RK surgery 20, 30 years ago who are actually coming down with cataract. So basically what is happening here is the IOL power calculation requires the axial length, keratometry, and the AC depth parameters. So formulas like SRKT, Hoffer-Q, Holiday 1 are dependent for the ACD measurements on the keratometer values for the estimated lens position. As you can see the picture in the B over here, these are the changes that take place post RK surgery. So basically after the refractive surgery, the central cornea power changes. There is progressive flattening of the central cornea. There is irregular astigmatism, which basically affects the ACD measurement and the estimated lens position. So the IOL formula that need to be considered in RK, we have the true K and the standard Haigis methods, which basically perform very good with only minus 0.5 diopters offsets. The advantage of the true K is that the magnitude of the RK correction is known. So true K basically uses the post-RK refraction and the current biometry to estimate the preoperative corneal curvature and the effective lens placement. So basically it predicts changes in the refraction using the axial length, the AC depth and the current keratometry to estimate the preoperative keratometry. In post LASIK, the IOL formulas that can be taken are the TK, that is the total keratometry. We have the Barrett TK2 formula. We have the Barrett TK toric. We have the Holiday EKR, that is EKR is equivalent keratometry reading that are taken from the pentacam, and the combination of all the formulas. So the equipments basically are required for the measurements. We have the OpScan and pentacam. Now the topography basically gives you more number of measurements of the cornea. It also gives you the measurement of the anterior and the posterior curvature of the cornea. We have the OCT, the abrometers and eye trace. And now we have the advanced biometers like the IOL Master 700 and the Lenstar LS 900. The advantages of these biometers is that it has an inbuilt software which basically calculates the power for post-refractive patients, and the chance of post-operative refractive surprises is very rare. And of course, those who do not have access to the advanced biometers, there's always a zero cost online calculator available, that is the ASCRS online calculator. Now all you need to do is you just have to enter the values. In case you have the preoperative pre-refractive surgery values, these can be entered. In case you do not have any pre-refractive surgery values, which is in most of the patients, you can just enter the values that are available with you, and with this the ASCRS online calculator will give you quite a good precise number. In case you're having access to both the ACRS online calculator and the biometer, you can always try both, and in initial cases you can see which works best for you, and you can continue in your practice with that. So then we have the intraoperative precautions that need to be taken for RK surgery. So because of the corneal incision, it is better to take a scleral tunnel incision, and if you are taking corneal incision, you would please take it between the incisions. If it is a 8-cut incision, you can take a 2.8 millimeter keratome. If it is a 12-cut incision, you can take a 2.2 millimeter keratome. So throughout the procedure, make sure the portal height is low, the AC should be maintained, and do not overfill the anterior chamber with viscoelastic, and always keep suture ready, and in case the incisions open up, please be ready to suture the incisions. Intraoperative precautions in patients with LASIK or PRK. In LASIK patients, it is very important to determine the LASIK position, the flap and hinge position, and do not disturb the flap position during the surgery, so that you do not want any epithelial ingrowth. In case of PRK, in case of haze, it's always better to stain the capsule with trypan blue for the excess. So the intraocular lens selection, post-RK or myopic LASIK patients exhibit better outcomes with aspheric IOLs that introduce a negative spherical aberration, like we have the IQ and the Technis lens. In hyperopic LASIK patients, they tend to do well with spherical aberration neutral IOLs, like the single-piece lenses. Now, it is very important to measure the spherical aberration, and it is crucial in the decision-making process. So you can utilize tools like pentacam, eye trace, and abrometers for a comprehensive assessment. Now, there are some contraindications for multifocal IOLs or toric IOLs, where in case of irregular astigmatism, which is shown on the topography, it is generally advisable to avoid multifocal and toric IOLs. Patient counseling, this I feel is the most important part. Now, definitely patients who undergo refractive surgery, they expect a bladeless procedure, they expect a wow factor, they want a 6x6 vision day one. Now, it is very important to counsel such patients that it is not the same outcome that you expect post-cataract surgery. Now, also patients who undergo refractive surgery, they might want a glass-free life because they've been leading a glass-free life, so they might ask you for a presbyopia correcting IOLs. So it is important that you educate the patients and tell them about the chance of glare, especially in those who have been induced to high-order aberrations post-refractive surgery. So post-operative surprises, in case of, again, counseling is very important. In case of any small refractive errors, it can be managed with contact lenses or glasses. Alternatively, we can do a PRK or LASIK for small errors to reach the desired refraction. And for larger amount of IOLs, you can always do a piggyback IOL or an IOL exchange. And again, it is very important to counsel such patients because we are reoperating on patients with high myopia, so there's always a risk of glaucoma, inflammation, or any retinal tears. So to conclude, implement various latest regression techniques and explore different methodologies for calculating IOL power. Use topographers or biometers for better keratometry, and of course ACRS online calculator is there, which is zero cost. And in case you have access, in case you have biometries like IOL Master 700, it gives quite an accurate calculation. And please do inform your patients about the possibility of unexpected refractory outcomes, and do manage them, and manage patient expectations regarding any post-surgery vision. Thank you.
Thank you, Dr. Advaith. That was a very comprehensive overview of post-refractive cataract surgery, and it's a very technically challenging area of expertise, because we need to, these are patients who are already in need of perfect vision. They've already sought the first surgery for freedom from glasses, and then we have to come for the second thing. We have to again satisfy their goal. So here I would add that probably when we do the IOL power calculation, we can depend on the optical biometer, the immersion, and the ACRS calculator, and use all of it to put together and get us the right power, and then make sure that it is consistent across all the three platforms. Another thing is we can also try and explore areas of enhanced monovision, like the true EDOF lenses in these kind of patients. They tend to do much better than the multifocal patients. So that would be my comment.
Yeah, so just to continue, what I usually follow is 3 machines, 3 readings. So all the 3 machines, that is the optical biometer, the immersion method, and the ESCRS, we have to calculate 3 readings, take an average out of all the 3. And actually I had a very nice point told by Dr. Samresh, who said that I show the patient, because these are post-refractive, there might be some refractive surprises. So you show the patient that we have done the best, this is the power we are going to implant. So you can see that we have showed them, write it down, and then we can say them that if any surprises come, they might need. So I think that was a very nice point which I heard from him, which I wanted to share, that show the patient that we have done the best, and this is what we are going to implant even before we are going to implant. Just wanted to share that. Thank you, Dr.